Very good afternoon to all. I think we are starting 5 minutes late, so I think we will be given that 5 minutes extra. So we are going to present a very challenging case of a pregnancy managed successfully post liver transplant. We've been managing successfully pregnancies after renal transplant over more than 2 decades, but we've not had a large experience of pregnancies managed successfully after liver transplant. And it is a good change to note that many women are surviving and looking forward to being enjoying the parenthood following liver transplant. And this case was successfully managed with the use of multidisciplinary team at AIIMS. And to discuss and present this case, I will invite our senior resident, Dr. Tanisha, who is going to present the case, and our assistant professor, Dr. Monica, who is going to review the literature, and we'll have the comments from the experts. So, Dr. Tanisha, please.
Good afternoon, everyone. Since India's first transplant in 1998, over 1,800 liver transplants are performed annually, out of which 10 to 20% of these women lie in the reproductive age. In AIIMS, this is our first case of pregnancy after liver transplant. So let's walk through this rare and remarkable journey. Let us meet Mrs. H. In the year 2013, when she was 21 years old, she was diagnosed with chronic liver disease with splenomegaly and pancytopenia. On workup, she was diagnosed with autoimmune hepatitis and she underwent disease donor liver transplant uneventfully in 2014. Post transplant, she was started on tacrolimus, mycophenolate mofetil, and prednisolone. MMF and prednisolone was stopped after 2 months. She also received famciclovir in the form of CMV prophylaxis for 6 months. 2 years post-transplant, she developed multiple biliary strictures for which she had to go ERCP 6 times at 2 monthly interval. Her last ERCP was at 2015 and since then she is stent-free. Again, after 2 years, she had an episode of upper GI bleed in 2016 and the endoscopy revealed grade 1 varices for which she was started on trabpropinolol 20 mg OD. Since 2016, Mrs. H has been stable and asymptomatic with no episodes of graft rejection, maintained on tacrolimus and magnesium. She married in 2022 and at the age of 32 years, she planned her first conception. When she came to us to get pregnant, she had multiple questions in mind. Am I eligible for this pregnancy? Will my transplant fail? Will the drugs harm my baby? Is it too risky for me? And what kind of care would I need? So we did a detailed preconceptional counseling for her, which included a detailed history and revealed no episodes of any rejection. She was normotensive and all the drugs which she was already taking was absolutely safe in pregnancy. We did her CBC, LFT, RFT, magnesium and TAC levels and except the platelets which were at a little borderline level, rest of the investigations were normal. So we started her on folic acid preconceptionally and she conceived spontaneously in 2 months. Moving on to the first trimester, the blood pressure was normal. In her blood profile, the tacrolimus was little lower than the therapeutic range, so her dose of tacrolimus was increased from 1.5 mg to 2 mg in the night, and she continued taking folic acid, calcium, magnesium, and propranolol. One of the most important component of first trimester is aneuploidy screening and screening for preeclampsia. We did her NT-NB and dual marker, which were normal for aneuploidy, but revealed a high risk of preeclampsia, 1 in 58. So we started her on TAP ecosprin 150 mg HS to be taken from 12 weeks. Moving on to the second trimester, she received Tdap vaccine. Now the tacrolimus level were little higher than the therapeutic range, and after discussing with the hepatologist, the level of the dose of tacrolimus was again decreased to 1.5 mg. The platelets continue to be at a borderline level of 94,000 and she continued taking iron, calcium, magnesium, propranolol, tacrolimus and ecosprin. A targeted anomaly scan was done at 20 weeks which revealed no gross anomalies. Moving on to the third trimester, she came to us at 28 weeks, received an influenza vaccine and all the blood profile was normal, so we kept her on weekly follow-up. When she came to us at 33 weeks in the OPD, her BP was 164 by 110 mmHg with a urine albumin of 2 plus with a normal per abdomen examination. We admitted her, quickly controlled her blood pressure initially with IV lobetalol 20 followed by 40 and eventually kept her on tab labetalol 20 mg TDS for optimization of her blood control. As we were anticipating premature delivery, we also gave her 4 injections of IM dexamethasone for fetal lung maturity. We ran her PIH profile, which included CBC, LFT, RFT, ACR, and fundus, all of which were normal. The normal LFT ruled out any signs of graft rejection at this point. So we made a diagnosis of pre-eclampsia without severe features with secondary thrombocytopenia. There were no signs of any graft failure. The fetal growth was appropriate for her gestational age, and she was discharged after 5 days at 33 plus 5 weeks on tab labetalol 200 mg TDS with bi-weekly monitoring. When she came to us at 34 plus 5 weeks, her BP again was 165 by 108 mmHg with no signs of impending eclampsia and a normal abdominal examination. She was again admitted with us. This time we increased her hypertensives to tab lobate 300 mg TDS and tab nifedipine 20 mg BD. When we again ran her blood profile, we saw now that the platelet had dropped to 35,000, which was a sign of severe features. So now she was diagnosed with pre-eclampsia with severe features and thrombocytopenia. Regarding the fetus, it was a longitudinal lie with cephalic presentation with a fundal height of 34 weeks. The clinically estimated weight was 2.5 kg. The pelvis was adequate with a Bishop score of 5 and the platelet count at that time was 31,000, pointing that we could deliver her vaginally. So the team decided that we need to deliver this patient immediately. This delivery was a difficult one, and we included the obstetrician, gastroenterologist, anesthesiologist, and neonatologist in the team. The induction was only started after arranging adequate amounts of RTPs and screening for STP. So the induction started at a Bishop score of 5, and she was first given an intracervical zero point 0.5 mg dinoprostone gel, and the fetal heart rate was monitored, which was reassuring. 6 hours later, when we reassessed her, there were no contractions. The Bishop was again 5, and we repeated the intracervical gel and kept the patient on continuous maternal and fetal monitoring. Again, 6 hours later, now she had mild contractions. The Bishop had increased from 5 to 7, but the contractions were not enough. So we decided to augment her with oxytocin at 2 millioninternational units per minute. 2 hours after oxytocin augmentation, we noticed that she had recurrent variable D cells on the CTG, which showed fetal distress. Her BP was 158 by 104 mmHg. On abdominal examination, the tone was increased, and vaginal examination showed a cervix of 3 cm, soft anterior 50%, showing that the Bishop was still 7. When we did artificial rupture of the membranes, the liquor was blood-stained. So she was diagnosed with placental abruption and was rushed to the OT for an emergency cesarean section. Inside the OT, we gave her general anesthesia and delivered a healthy baby quickly who weighed 2.3 kg with an ABGAR of 8 and 9. The liquor was blood-stained and there was 20 ml retroplacental clot and the uterus was covular as shown in that image. Few seconds after delivery of the baby, she had atonic PPH. We started management. Initially, medically, we gave her oxytocin, tranexamic acid, carboprostol, and misoprostol, and also gave her 1 unit STP, 3 units RTPs, and 2 unit FFP. The bleeding did not resolve, and we decided to go for AIIMS sutures, which is a type of uterine compression suture to gain the tone of the uterus. The bleeding had resolved after applying AIIMS suture, and the total blood loss was 1.2 liter, and the patient was shifted to a recovery area in stable condition. In the postpartum course, the blood pressure was persistently raised and we kept a close watch. She continued breastfeeding with tacrolimus and magnesium, and she was discharged uneventfully at post-op day 3 on amlodipine 5 mg OD. Following her 6 months postpartum, now she has developed chronic hypertension with her blood pressure controlled on tab amlodipine 10 mg OD, and the baby is doing well. Now I would like to call Dr. Monica ma'am for the discussion.
Good afternoon, everyone. Proceeding with the discussion, women with decompensated chronic liver disease often face anovulation, amenorrhea, and infertility due to hormonal disruption because of estrogen metabolism and endocrine dysfunction. But after liver transplantation and restored hepatic and hormonal function, there is an expected return of fertility within 6 to 12 months. Pregnancy post-liver transplant was once considered contraindicated because of the high risk for graft loss, rejection, and obstetric complications, as well as lack of availability of safe immunosuppressive drugs. But now it is a well-managed possibility with a stable graft function, optimal immunosuppression, and multidisciplinary care. So a safe and successful pregnancy is now achievable. We have to have a pre-pregnancy optimization, manage the challenges associated with pregnancy, delivery, and contraception. In pre-pregnancy optimization, we have to take a comprehensive medical and transplant history, ensure multidisciplinary preconception counseling with transplant team, hepatologist, and maternal fetal medicine team on board. Pregnancy must be deferred for 1 year after liver transplant to achieve a stable allograft function with no history of recent graft rejection, stabilize the associated medical comorbidities, and achieve a normal baseline liver function and renal function test. Because a baseline renal function test dysfunction is associated with poor outcomes as well. We have to review and adjust the immunosuppressive medications, stop teratogenic medications early, and confirm that the patient has received cytomegalovirus prophylaxis in the post-transplant period. If the patient is taking oral glucocorticoids, azathioprine, cyclosporin A, and tacrolimus as immunosuppressive agents, they can be continued safely for pre-pregnancy during counseling as well as pregnancy. However, mycophenolate mofetil is teratogenic and needs to be stopped 6 weeks prior to conception. Sirolimus and everolimus are teratogenic and they need to be stopped 12 weeks prior to conception. There is limited data on belatacept and the approach has to be individualized on this drug. As we can see, the maternal risks in liver transplant recipients are increased in as compared to the normal population. So there is a risk of 20 to 30% hypertensive disorders, preeclampsia as well as gestational hypertension, 8 to 15% gestational diabetes mellitus. They have an increased chance of undergoing cesarean section, which is 40 to 60%, 7% risk of intrahepatic cholestasis of pregnancy. With a baseline stable allograft function, the rejection episode is minimal. We need to identify graft rejection episodes from the symptoms as well as multiple investigations. So the patient will have fatigue, malaise, right upper quadrant abdominal discomfort, jaundice, which may overlap with other complications of preeclampsia and pregnancy. There will be rising transaminases, bilirubin, GGT, and ALP. On Doppler ultrasound, there will be reduced hepatic artery flow and biliary radical abnormalities. Liver biopsy is the gold standard for diagnosis, and the differentiation from HELP, severe IHCP, and acute fatty liver disease of pregnancy is challenging. With close multidisciplinary monitoring with the transplant team, this graft rejection can be identified and successfully managed. The recommendations for maternal risks are that we need to start low-dose aspirin for prophylaxis of preeclampsia from 12 to 16 weeks, which is 75 to 150 mg aspirin at bedtime dose. Monitor the liver function tests every 4 to 8 weeks with an aim to keep them below 1.5 times the upper limit of normal. And monitor the tacrolimus levels with a therapeutic target range of 5 to 15 nanogram per milliliter every 4 weeks until 32 weeks, then every 2 weeks until delivery, and then weekly in the postpartum period up to 6 weeks. And then adjust the doses as per serum levels and clinical status with the hepatologist on board. Fetal risks, as we can see, there is an increased risk of preterm delivery, which is 20 to 40% as compared to 5 to 10% in the normal population, and 1 to 5% risk of stillbirth as compared to 0.6% in the normal population. The risk of neonatal death are similar. The recommendations for the fetus are that we need to do the first trimester combined screening, including NT-MB scan and dual markers. If we are using cell-free DNA, then we have to screen for trisomy 13, 18, and 21 only, excluding the sex chromosome analysis. Routine anomalies, a detailed anomaly scan is to be done at 20 to 22 weeks, and serial growth scans every 4 to 6 weekly, and a Doppler is done if fetal growth restriction is suspected. And antepartum surveillance starts from 32 weeks and earlier if complications demand so. Delivery has to be planned and at 37 to 39 plus 6 weeks. Vaginal delivery is the preferred route of delivery. It is safe with high success rate, low neonatal morbidity, and there is no increased chance of graft rejection. Cesarean section is to be done only for obstetric and medical indications. And if the patient is on chronic dose of corticosteroids, then stress dose needs to be given in labor. For cesarean section, a phalanx steel incision for the skin and low transverse hysterotomy incision are safe. The lactation is breastfeeding is to be initiated and is to be encouraged. And during lactation, tacrolimus, corticosteroids, azathioprine, and cyclosporine can be continued. However, mycophenolate, mofetil, and sirolimus, if required, then breastfeeding has to be discouraged. Long-acting reversible contraception are the first-line contraception mode, and intrauterine devices like copper T are safe. Progestin-only devices like implant and DMPA injections are also safe and effective, and combined oral contraceptives are contraindicated. Coming to the review of literature. So we have a case series from Amrita Institute, Cochin, a single center experience of 7 cases of liver transplant recipients who had pregnancy and managed with 6 live births, and all the babies and mothers did well after delivery. Coming to a large systematic review and meta-analysis from United States of America, which was over a period of 30 years, and including 38 studies and 1131 pregnancies among 838 liver transplant recipients, they found there was a live birth rate of 80.4%, and we can see that the obstetric complications like miscarriage rate 16.7%, was similar to general population. However, the risk of preterm birth, preeclampsia, cesarean delivery among the liver transplant recipients were higher than the rates of general population of the United States of America. From this paper, which is very recently published in July 2025, we want to emphasize how important is the preconception planning and pre-pregnancy optimization to avoid unintended pregnancies. So as we can see, when we compare unintended pregnancies with meticulously planned pregnancies, the mycophenolate mofetil use has been found to be very high, 12.8% versus 3.5% in the unintended pregnancies. Acute cellular rejection rates were also high, 3.7%, having a low median birth weight, which was again lower than the planned pregnancies, and graft loss of 14.3% versus 6.4% in the planned pregnancies. So we emphasize that pre-pregnancy optimization and multidisciplinary counseling is as important as the management itself. Now I invite Professor Shalimar from the Department of Gynaecology for his valuable opinion.
So at the outset, I'd like to congratulate the team and the department for successfully managing the patient. You've been helping us a lot managing all our liver patients who really are young females who are planning pregnancy and unfortunately are not going to have conception, especially with our birth theories. And I really thank the department for managing our patients who are anticoagulants and have lots of support. They have a very turbulent course during pregnancy, after delivery, but we've been taking good care. This patient was very different actually. So when I saw this patient, I gave a call to the department asking whether would you be interested in managing it, because we've never sent any of our patients to, and we've never seen, this was our first patient who got pregnant post liver transplant. So I was really also confused as how are we going to manage it as we don't have any experience. But then the team took up this challenge, and the end what we see is that it was so successfully managed. So I congratulate you and thank you. And we look forward, because we will have more and more patients, because as the transplants are increasing in numbers and India is becoming the hub. And within the next decade or so, India will have the highest number of living donor liver transplants. And I'm sure DDLT is also going to pick up over time. We're going to have more and more patients who are going to get pregnant, and we need your help in managing their pregnancy time, and I'm sure you bring joy to all of these families. Thank you. Thank you.
Thank you, sir. Now I invite Dr. Neha.
So, the transplants are done here, transplants are outside, but then she came to us for the delivery, for the management, and when she got pregnant, she was referred to us first for the management part, and then I took on only that I would be willing to take care of her pregnancy part if my gynae department agrees. Once the team agreed, then only I called her for managing the pregnancy. It's a So management was done completely here, but transplant's not done in the institute.
Thank you, sir. Now I invite Dr. Neha, Assistant Professor from the Department of Anesthesia, for the anesthesia.
Good afternoon, everybody. I would like to thank the Gynae department, Professor Ganga sir and Mimi ma'am, for giving me this opportunity to speak on the topic. So I will be talking about the anesthesia concerns in parturient patient, in a post-liver transplant patient. Introduction. Pregnancy in post-liver transplant patients is considered high risk. This is mainly because of the increased risk of obstetric and medical complications which is present in these patients. Second concern is adverse effects of immunosuppression and the sequelae of liver failure which fail to resolve after transplantation. The American Association for Study of Liver Disease and the American Society of Transplantation have recommended delaying conception for at least 1 year following liver transplant to stabilize the graft function with reduced immunosuppressant dose and for optimal control of medical complications associated with liver transplant. So why are we having an issue when we have transplanted the liver and the liver is functioning normal? So why are we having the issue? Basically, there is a loss of autoregulation of the liver. Normally, there is autoregulation, and whenever there is an increased blood loss, there is autotransmission through vasoconstriction in the liver. So hypovolemia and hypotension is reduced in the initial phases. This autoregulation is lost in transplanted liver. Moreover, the physiological mechanisms that protect hepatic blood flow are blunted. Thus, the liver allografts are more susceptible to hypoperfusion and hypovolemia. These can be prevented by left uterine displacement, intravenous fluid administration, use of vasopressors, and using stockings in the leg. The pre-op assessment of a parturient post-liver transplant includes assessment of the graft function, assessment of common medical conditions of a liver after liver transplant like hypertension, CAD, diabetes, and renal dysfunction, the persistent sequelae of the end-stage liver disease like pulmonary hypertension. Then there are immunosuppression-related comorbidities. There might be presence of infection and general obstetric complications which are increased after liver transplant. The problem with immunosuppressant agents is that it increases the risk of infections while providing anesthesia, especially during regional anesthesia and placing invasive lines. They have additional side effects like hypertension, diabetes mellitus, obesity, anemia, and thrombocytopenia, which have additional risk, which place the pregnant patients to additional risk of anesthesia. Specific concerns with cyclosporine and tacrolimus include renal microcirculation is reduced, and thus, because of the renal dysfunction, we have to safely use a few drugs like NSAIDs, ranitidine, cimetidine, which have effects on the renal function. Cyclosporine, in addition, increases the effects of barbiturate, fentanyl, and non-depolarizing muscle relaxants, and the doses of these have to be decreased, and the dose of isoflurane has to be increased. Coming to the anesthetic management in parturient post-liver transplant, the antibiotic prophylaxis is advised as in all clean, even in the clean surgical procedures because of the immunosuppression. Tacrolimus must be administered at least 4 to 7 hours before surgery because of reduced gastric emptying. And drugs that affect cytochrome P450 mechanism, which can affect the level of immunosuppressants, have to be given in the normal dose and cautiously. The choice of anesthesia can be general anesthesia and regional anesthesia depending on the graft function, cardiopulmonary status, renal involvement, and presence of obstetric complications. Regional anesthesia is preferred wherever possible. However, general anesthesia is more frequent because of increased incidence of emergency LSDs, which do not give us time for regional anesthesia. So there are alterations in the drugs used for GA because of the biliary stasis, because of strictures, because of the renal insufficiency. We have to avoid the drugs which get excreted by the kidney. Then we have to administer drugs which do not have organ-dependent elimination like atracurium, ramipril. So the drugs have to be closely decided in the pre-op what can be given and given accordingly. For regional anesthesia, epidural analgesia for labor is also possible in these patients, but because of the increased risk of infection, epidural analgesia and spinal block have to be given in strict asepsis. And because of the diminished inflammatory response, which may mask the usual signs and symptoms of neuraxial infections, early removal of epidural catheter is recommended. Preloading before the subarachnoid block and early vasopressor should be used to treat hypotension. So, in detailed intraoperative management, strict asepsis, especially for invasive light insertion and neuroaxial anesthesia, should be done. These patients have a history of prolonged ICU stay with prolonged CVP insertion. So, there is an increased chance of thrombosis and stenosis of the central vein. Thus, ultrasound guidance is advised in all patients where CVP has to be placed. The patients have increased blood transfusion requirement because there is thrombocytopenia and increased incidence of anemia. Another thing of concern is because these patients have already received multiple transfusions, there is presence of autoantibodies against the RBCs. Thus, leukocyte depleted and irradiated blood products are recommended. Additionally, hemostatic abnormalities may enhance the risk of PPH in the post-op period. In the post-operative period, the patient should continue to receive analgesics in which paracetamol and epidural boluses are preferred, and SIDS should be avoided because of the risk of reduced renal blood flow. Antibiotic prophylaxis should continue. Immunosuppressive therapy should be resumed as early as possible in consultation with the hepatologist. Antihypertensive therapy is often needed, and prophylaxis against venous thromboembolism should be given.
Before the take-home message, I would like to invite Dr. Ankit from neonatology. As with their help and thanks to them, we were able to discharge the patient in 3 days.
Yeah, thank you, ma'am. So I just want to give a simple message. If the mother is taken care well during her pregnancy, then the baby is delivered well. So majorly, the patients who are having post-hepatic this liver transplant, they tend to deliver healthy neonates, and this medication tacrolimus, it's safe to use both in pregnancy as well as during the lactation. There is minimal side effects in terms of any birth defect or any the secretion into the breast milk is also minimal. So this drug can be safely given to the mothers, and the babies they are delivered healthy. So yeah, that's all for myself.
Thank you, sir. So, for the take home message, preconception optimization is the key with multidisciplinary vigilance during the pregnancy and high risk surveillance for preeclampsia, hypertension, and thrombocytopenia. And with a planned and coordinated delivery, we can achieve high success rates in these cases. Thank you. I would like to invite Professor Neeta Singh to deliver the vote.
So you can see from this case that with a very coordinated team effort with the help of Dr. Shalimar, who was assisting us throughout this pregnancy, and among the other multidisciplinary team, we were able to achieve a very successful outcome. And as he said that we are looking forward to manage many more pregnancies with more confidence as we get more experience. That initially when this lady came that we didn't have much experience and we had to review literature that how other centers are managing pregnancy in liver transplant, but I'm sure that we are more confident after this success that we'll be able to offer these women who are looking forward to a happy parenthood to give them a successful outcome. Thank you very much for a patient hearing, and I invite any comments from the audience. Anybody who would like to say, Dr. Bibi, want to say something? That was an unintended pregnancy. 6.4%. Yeah.
Or something like a system. That could be the other factor which could influence your. Yeah, but then it also depends what kind of disease, like if it's controlled, with respect to the food, we're not looking at any new problems or complications. I believe that not be much.
during the course of pregnancy.
Okay. There's no more questions?
And are they candidates for fertility preservation, the transplant patients?
It depends on what age the patient is, not for fertility preservation. As we said that if the transplant is successful and after 1 year of post-transplant, these patients can successfully conceive. If they do not have spontaneous conception, we can offer them other assisted conception techniques as well now because the graft is stable. But there is no need for fertility preservation. Why would we preserve fertility?
This is safe.
Yes.
You do not do pre-transplant as well.
Most of these patients, they have been shown, she showed in the chart that what immunosuppressants are generally given, except for mycophenolate mofetil, which is contraindicated, and sirolimus, which is contraindicated. All the women of reproductive age group mostly are given tacrolimus and corticosteroid these days, and even azathioprine also. Like we are managing post-renal transplant pregnancy, and we have a very large experience of managing post-renal transplant, and most of these renal transplant patients are on tacrolimus. So it is very safe. So we are not scared of tacrolimus at all now.
And one question for Dr. Okay, so since tacrolimus is also secreted in the breast milk, so do you think first immunization should be delayed because it can potentially lead to B-cell?
So, sir, actually, we did a literature review, and it seemed that tacrolimus is basically protein-bound drug. So the secretion into the breast milk is minimal, and there have been case reports in the literature where they have followed the tacrolimus levels in the breast milk. So what they found that the tacrolimus levels in the breast milk are just around 0.05%, 0.5% of the normal prescribed dose which we give in pediatric population. So that such less amount of dose, it's quite unlikely it will lead to immunosuppressant. So we can give them immunization safely.
Thank you very much. Thank you very much.